Patrick has a history of left-sided heart failure which was likely caused by his myocardial infarction in his left coronary artery. As a result, the left ventricle pumps ineffectively, resulting in blood accumulating in the pulmonary circulation, thus increasing the hydrostolic pressure of the pulmonary veins and capillaries. This causes pulmonary edema, as fluid is compelled into the interstitial and alveolar spaces. In Patrick's case, he has developed dyspnea, which is a common backward effect in the early stages of heart failure, as the result of pulmonary edema causing suboptimal gas exchange in the lungs. Patrick's other respiratory symptom is a persistent cough, which is another backward effect of the left-sided heart failure and is the result of bronchial irritation associated with pulmonary congestion. Patrick also has a history of chronic obstructive pulmonary disease, or COPD, which would contribute to his respiratory symptoms of regular coughing and dyspnea. Persistent coughing related to COPD is caused by chronic airway inflammation, likely due to Patrick's 40-year history of smoking. Patrick's heart rate of 155 beats per minute is determined as tachycardia. Due to Patrick's MI, he has permanent damage to the cells resulting in inadequate function. Tachycardia is a compensatory mechanism where the remaining heart cells are forced to work harder and faster in an attempt to respond to the low levels of blood reaching the systemic circuit due to his lower cardiac output. The tachycardia means the heart is working harder and requires a greater oxygen demand. The decreased cardiac output from the left ventricle of the heart into the aorta and the systemic circuit from impaired contractility triggers a sympathetic branch of the autonomic nervous system to release adrenaline and noradrenaline. This is detected in the cardioexcitatory center and causes an increase in heart rate and vasoconstriction of the arterioles to increase blood pressure. The juxtaglomerular cells in Patrick's kidneys detect the systemic decrease in blood volume, and this triggers the renin-angiotensin-aldosterone system to retain sodium and water to increase blood volume to increase blood pressure. The posterior pituitary gland also detects the decreased blood volume and stimulates the secretion of antidiuretic hormone, causing the kidneys to retain excess water and increase blood pressure. Left heart failure causes both an increased preload and afterload, decreased contractility, and causes a greater oxygen demand for the myocardial tissue, which is why Patrick is experiencing tachycardia. COPD and left heart failure share the common risk factors of smoking and advancing age. However, they are two independent disease processes with secondary contributing factors to one another. COPD is an irreversible disease categorized by two disease processes, emphysema and chronic bronchitis. Emphysema causes irreversible damage to the alveoli in the lungs, affecting their elastic recoil. This causes air trapping and impedes normal respiration ability and adequate gas exchange, and results in low forced vital capacity and low forced expiratory volume per second. Chronic bronchitis is caused from damage to the epithelial lining of the airways that triggers an inflammatory response. This results in constriction and excessive mucus production, as well as impaired ciliary function resulting in airflow limitation and hypoxemia and hypercapnia. Patrick's COPD was likely caused by his 40-year history of smoking, which is the most common cause of COPD. Patrick's left heart failure was caused by an MI to the left branch of the coronary arteries. The MI was likely the result of coronary artery disease due to his risk factors listed on the slide. It is likely that COPD contributed to and is worsening Patrick's left heart failure, as COPD causes increased airway resistance and airflow limitation. This increases negative intrathoracic pressure and the transmural pressure placed on the left ventricle. Therefore, the left ventricle has to work harder, leading to ventricular remodeling, which can result in left heart failure. This increases the workload of the left ventricle and oxygen requirement of the myocardium. COPD is linked with not only pulmonary inflammation, but also systemic inflammation, which is a risk factor for developing cardiovascular disease, which may have contributed to Patrick's MI and subsequent left heart failure. Both COPD and left heart failure can cause pulmonary hypertension, which exacerbates both conditions. Pulmonary hypertension can lead to pulmonary edema, causing dyspnea, hypoxemia, and tachypnea, all of which worsen Patrick's respiratory symptoms. Pulmonary hypertension also increases the preload of the left ventricle, which increases the workload of the heart and will worsen left heart failure. Unfortunately, Patrick is at risk of developing right-sided heart failure due to his COPD, left-sided heart failure, and systemic prehypertension. In Patrick's case, right heart failure could be caused by pulmonary hypertension, which increases the right ventricular afterload. Due to the increased afterload, the right ventricle has to continually work harder, resulting in ventricular remodeling. Right ventricular remodeling results in poor contractility of the right ventricle, an increased oxygen requirement of the myocardial cells, decreased cardiac output, and poor coronary circulation. Patrick's left heart failure also places him at risk of right heart failure. This is because left heart failure impedes normal forward blood flow into the systemic circulation. This has a backward effect, causing congestion in the left atrium and pulmonary circulation, resulting in pulmonary hypertension. He is also at an increased risk of coronary artery disease due to his risk factors listed on the slide. Hypoglycemia, an increased risk factor for coronary artery disease, increases the risk of Patrick suffering another MI. If a right MI was to occur, this could result in right-sided heart failure, whereas if another left MI was to occur, it would worsen left heart failure, which in turn leads to right heart failure. Patrick's elevated potassium and sodium levels, decreased calcium and hemoglobin levels, and peripheral edema all indicate possible renal impairment, which is a known risk factor for cardiovascular disease, further increasing Patrick's risk.
Patrick's chronic heart failure may have elevated his sodium level, indicating hyponatremia. Increased extracellular sodium stiffens endothelial cells, reducing the release of nitric oxide and increasing secretion of von Willebrand factor, increasing risk of stroke and mortality. Hyponatremia is indicative of a fluid imbalance, possibly due to Patrick's hypoglycemia or impaired kidney function, potentially leading to neuronal dehydration, resulting in CNS hemorrhage, seizures, neurological deficits, and coma. Patrick's elevated glucose and dyslipidemia due to raised triglyceride and low HDL levels suggests metabolic syndrome. Metabolic syndrome can be associated with cognitive decline due to hypoglycemia or the presence of inflammation and increased risk of dementia and stroke. Patrick's elevated low-density lipoprotein cholesterol attributed to his increased waist circumference is frequently associated with consumption of saturated fats. High LDL levels increase artery plaque accumulation, leading to narrowing and atherosclerosis, potentially resulting in peripheral artery disease and further increasing Patrick's risk of heart attack or stroke. Elevated potassium, possibly from Patrick's impaired kidney function, increases risk of hyperkalemia. The kidneys are essential in potassium homeostasis, responsible for the excretion of ingested potassium. Chronic heart failure medication can impede the RAS, and with only small reductions in GFR can also result in hyperkalemia. Neurological symptoms can include fatigue, decreased motor strength, or reduced deep tendon reflexes. Patrick's low calcium levels, likely caused by his kidney failure, could suggest hypocalcemia. Calcium homeostasis is vital for neural transmission, intracellular signaling, and cell function. Occasionally, severe hypocalcemia can cause seizures and tetany. Low hemoglobin levels, indicative of anemia, are likely due to Patrick's kidney disease and could be contributing to his fatigue and dyspnea. Anemia can affect neurological function by impacting sleep, reducing cognitive function, and causing dizziness.
An arterial blood gas analysis would be recommended for Patrick to provide further information pertaining to his respiratory and cardiac function. The results from this analysis would be abnormal and would likely show changes in Patrick's acid-base balance and his oxygenation status. This would provide the information needed to effectively treat Patrick's declining health. We would expect to see a lower than normal level of the partial pressure of oxygen due to his inadequate gas exchange from his COPD and the impaired oxygen carrying capabilities and tissue perfusion from his anemia and left-sided heart failure. We would see changes in his carbon dioxide levels indicating hypercapnia due to his airflow limitation from his chronic bronchitis, as well as damage to the alveoli from his emphysema. Due to Patrick's suspected renal impairment, it is unlikely that his normal renal buffer systems for acid-base balance regulation can compensate adequately, resulting in a declined blood pH, indicating respiratory acidosis, and when we consider this in conjunction with his earlier test that indicates he is hyperkalemic, we could ascertain the severity of his respiratory acidosis. Serum bicarbonate levels would likely be lower, indicating possible metabolic acidosis. Patrick's oxygen saturation levels would be lower than normal due to his left-sided heart failure, COPD, and his low hemoglobin levels. Both compensation mechanisms for Patrick are likely impaired, and therefore an arterial blood gas is an essential diagnostic indicator to appropriately guide health professionals in treating Patrick's condition and potentially saving his life.